All right. So, good morning, everyone. On behalf of the Emergency Medicine Residency Program at the University of Central Florida, HCA Florida Healthcare, Greater Orlando Osceola program, we want to welcome you to another session in the 2023 Faculty Development Series.
So thank you in advance for your active participation. As you probably are aware, but we want to remind everyone that this activity is designated for a maximum of 0.5 AMA credits. So just make sure that after the session, you fill out the evaluation via email so you can get credit for it.
And we are your facilitators for today.
Yeah, I'm Dr. Vera. I'm a fellowship trained board certified pediatric EM physician and the associate program director for our emergency medicine residency.
And I'm Dr. Shayne. I also have a master's in medical education and serve as the director of education for our program here at UCF. And today we're talking about giving feedback.
Here are our objectives for today's session. At the end of the session, all of the participants should be able to define feedback and discuss the importance of feedback in our current system of competency-based medical education. We should be able to interpret the ADAPT framework and analyze its applicability to the clinical environment in the emergency department. And finally, we should be able to apply the ADAPT framework to your next educational encounter.
So let's start off with some definitions. What exactly is feedback? Merriam-Webster defines it as the transmission of evaluative or corrective information about an action, event, or process to the original or controlling source. And specific to medicine, feedback is information describing students or house officers' performance in a given activity that's intended to guide their future performance in that same or related activity, and is an essential element of the educational process that helps trainees reach their maximum potential. It enables learners to achieve the course or program goals by reinforcing good performance and providing the basis for remediation when needed. And it's even more important in today's medical education world, where we've moved away from the structure and process-based theory of the past. And now we're focused more on a competency-based system with increased focus on achievement of milestones and learning outcomes. And as you can imagine, specific detailed feedback on performance coupled with opportunities to improve will lead to achievement of these milestones. So we probably all agree now feedback is important. It's critical. And feedback allows learners to gain awareness about their performance and directs their future improvements. Given this importance, perhaps unsurprisingly, teachers believe that they give frequent and adequate feedback to their learners. However, learners report that the feedback they receive is infrequent and ineffective. And there are many perceived barriers to this, I would argue more so in the emergency department, that could prevent adequate, frequent, and effective feedback from taking place. Although this lecture might suggest otherwise, many times the purpose of feedback is unclear to faculty and to learners. And additionally, there are perceptions about the lack of appropriate timing or space to provide feedback, again, especially in emergency department. Another contributor is the lack of formalized training in providing effective feedback. Because faculty aren't actually equipped to perform it, then they won't. And additionally, many faculty lack confidence about their observations, again, intensified by variability in speed and oversight in the ED. And finally, faculty oftentimes are unable to translate their observations into meaningful and specific constructive feedback. So given this busy environment, especially in the ED, these barriers are more pronounced. So we need some tools and strategies to assist us in providing adequate feedback. I'll go briefly over some of the tips offered in this 2012 paper in Medical Teacher, and we're going to spend a lot more time later on a specific framework to help us in the ED. So tip number one, establish a respectful learning environment. And this environment should promote the concept that we as faculty and our learners are working together to help them achieve desired outcomes. So together we must mutually agree that observation of performance and regular feedback will occur in an atmosphere of mutual trust and respect. And interestingly, when medical residents were surveyed, they stated that trust and respect for their teacher are main factors that would make them more receptive to feedback. Tip number 2 is communicate goals and objectives for feedback. And as faculty, this is really on us to clearly communicate these goals prior to their learning experience. Tip number 3, base feedback on your direct observation. So as they progress from novice to a competent practitioner and beyond, more experienced physicians and educators should observe their performance and note these important areas of success or remediation. And it's important that it's based on your direct observation rather than hearsay from multiple other sources. 4 is make feedback a timely and regular occurrence. And one of the most important purposes is for it to be formative, and that is to enable the learner to make needed changes before the end of a course or a shift or a rotation if the behavior needs correction. So we got to provide feedback as soon as possible after this encounter, and they have sufficient time to act to fix it. And I'll go briefly through the rest of these, but again, we're going to talk more in detail about some of these in a framework to assist us. So always start with their self-assessment of how an interaction or activity or procedure or patient went. That'll give you a lot of insight as to whether the student or resident actually is aware of their deficiencies and successes and can help target your specific feedback moving forward. Then we want to reinforce and correct observed behaviors, followed by using specific neutral language. So this is, getting away from the good job or do better. You want to give really specific feedback that they can utilize to fix in the future. Next up, confirm their understanding. Make sure that after you've completed the feedback session that you're making sure they completely understand what your expectations are moving forward. And coupled with that is to develop an action plan together. Always reflect on our own feedback skills as faculty and how we can do better. And tip number 11 is create staff development opportunities like this 30-minute session we're sitting through right now. And hopefully all together as faculty, we can make this a part of our institutional culture to lead to a better educational environment for our residents. So now I'll turn it over to Dr. Vera to talk about a framework.
Yeah, so we're going to expand based on what Dr. Gu mentioned, and we will go over one method that incorporates many of the tips that we just went over. There's other methods out there, but this one is evidence-based, and the technique was developed by Susan Johnson and others at the University of Washington. The method is called Prepare to Adapt, and it's a 5-step framework for effective feedback. It's been demonstrated to decrease anxiety, but most importantly, it actually increases the efficiency of the feedback, the frequency, and the usefulness of the feedback that we provide to our learners. These are the 5 steps that we will be discussing. You first start by preparing, then you actually perform, or the learner performs the activity that you're going to be observing. Then you ask, then you discuss a little bit further, you ask again, and you finish by making a plan together. So we're going to go now step by step, but what we mean by that. Now, it's important to highlight that the relationship that we want to have, it's with the residents, is a relationship between an educator, specifically a coach, and a trainee. So this means that both of them have responsibilities and expectations for the feedback process, but in the end, they must work as a team. This model provides a framework for both sides. So you will see on the left how the process should go if the learner is the one that is initiating the feedback. But I want you to focus on the right column, which is going to have the steps to when we are the ones that are actually starting the feedback process. Okay, so it's going to be initiated by us, the educator. The first step, like I mentioned earlier, is to prepare for the observation. In this step, we should kind of set expectations with the learner, and those expectations are going to be based on our specialty, in this case emergency medicine if you're coaching an emergency medicine resident, and also the level of training. So it's not going to be the same if it's a PGY1, a PGY2, or a 3. An important thing also is to assess how ready the resident is to receive the feedback. In the end, the goal is to make a meaningful change. And although the feedback is most effective when it is given close to the encounter, at times the resident may not be in the right place. That could be like the physical space, or mentally is not the right place to receive the feedback. And we should kind of choose a different time to do this. This also helps to label the interaction, like this step helps to label the interaction as giving or receiving feedback. And again, you want to do it explicitly. It's been demonstrated, like Dr. Gu mentioned earlier, that many feedback interactions are not actually perceived as feedback by the learner. So making it clear is actually going to be helpful for both. One situation that we can possibly encounter here is that maybe the learner, it's already meeting all expectations, and sometimes we find it difficult to find the area that he should improve. So in this stage, you should also ask the learner, what are their goals? What are the areas that maybe they struggle with? And that could be the starting point to the rest of the encounter. The following step, it's not necessarily a step in the model, it's just the interaction that should happen, the observation. This could be brief interactions, it could be observing the patient, the resident giving back news to a patient, or maybe performing a procedure like an intubation. Sometimes it can also be a broader observation that happened throughout a whole shift. The important thing here is to be neutral. Both parties should be neutral. And so in case of the coach, try to be an invisible third party, try not to interrupt unless it's like medically necessary or if the situation warrants it. But otherwise, just try to observe and see the whole encounter on its own. The second step is to ask. In this stage, you're going to engage the learner and ask how they think the interaction went. Okay, this is something that we do often in the simulation field. This will help it will help the learner analyze their performance. And many times they will make good observations on their own, and at times that may not be the case. But this step will help give us an idea of what is the learner's mental model. And you can kind of get a little bit more into how are they thinking? Do they have self-awareness of the opportunities that they have to improve, or are they not even in that stage yet? Other ways that you can ask is to ask, what was the interaction like for them? What went well? What did not go as planned? The third step is to discuss. And in this stage, you're just going to have a conversation with your learner. Now, it's essential that you should focus on the behavior at this stage, not on the person or the outcome. So using a proper language is going to have a great impact on how successful we are in delivering the news or the discussion. Practice using phrases like I noticed, I heard, instead of saying you did this, you did not do this, you forgot about this part. Other examples, you could say, I noticed the patient looked confused after you explain a lumbar puncture procedure to the patient. I noticed that it took you additional time to find the left upper quadrant view during your FAST exam. This helps to personalize the feedback and increases the likelihood that it's going to have the desired effect. It's also helpful to focus on just one or two behaviors. Sometimes we try to focus on too many things, and this will also not help in terms of delivering what we want. Finally, we will be more successful doing this stuff if we allow ourselves to look imperfect. So if we don't always have the same experience or example, but if there's a personal example that you have that applies to that encounter, then we should share it with the learner. It will help normalize the behavior of just kind of relating on your experiences and just the culture of learning, the culture of growth. The fourth step is to ask again. So this is equivalent to using closed loop communication. After you did the discussion, now we want to ensure that the message was received as intended. So you can ask the learner, what was your main takeaway from the discussion? Can you give me one part that was useful to you? what will you do differently next time? And finally, use this step to clarify any points that need clarification. If they're what they got from the discussion was not what was intended, then this is the time to correct it. And our final step is to plan together. So coach your learner to the next level, make suggestions that are action-oriented and based on behavior. So summarize what you did, and then plan what's next. So the next time that that you deliver bad news, I want you to do X, X activity or X change in your approach, and that will kind of make it more feasible for the learner. So again, prepare, then perform the activity that you're going to observe, ask, discuss, ask, and then plan together. We're going to go over now through a scenario on how the ideal interaction would look like. It takes practice. It doesn't always come as we want. I wish I could say that my interaction, this is actually from a real kind of encounter that I had with a resident. It didn't necessarily went as this, but this is what I would have liked it to go. So, the attending knows they're going to have to do a procedure. So he addresses the resident and he says, we need to perform a lumbar puncture. So you mentioned that you have struggled in the past with this type of procedures. And as a PGY3 level resident, you should be able to perform this procedure independently. So I want you to observe, I want to observe you while you perform the procedure on improving your skills. What do you think? You want to make sure that the resident, again, is in the right mindset. He's ready to receive the feedback. So he says, yes, I do struggle with finding the correct space to insert the needle in certain patients, and I always seem to get a bloody tap. So again, this allowed you to learn about your learner, about your resident. So now you know what he struggles with, and you can actually make a mental note and sometimes even a physical note of what you want to observe. So in this specific case, does the resident look for the proper alarm marks when he's about to do the LP? Does he put the patient in the proper position? What technique does he use when he's doing the LP? And again, so now you have something to look for when he does the encounter. So you observe the resident, and what you see is that the resident, he struggled in the beginning. He needed help finding the space to put the needle. And then after he was able to find the space, he was able to get the sample head, but you notice that he went too deep with the stylet. And once he removed the stylet, a bloody tap came out. So now that the observation occurred, you want to ask the learner, how do they think that went? And so the resident says, I think it went well as I got the CSF sample, but I needed help finding it. I did not kind of find it on my first attempt, and I still got the bloody tap, which again is what he was having trouble with. So the attending acknowledges that, yes, and I noticed that you inserted the needle too deep, which may have contributed to your bloody tap. At times, sometimes it's difficult to find the correct space, especially in infants. So it is easy to insert the needle farther than the usual as the layers are closer together. I used to have this same struggle in the past. One technique that can help you and help me is using the early stylet removal technique. And this allows you to stop advancing the needle as soon as you see CSF, and it decreases the incidence of a bloody tap. Again, you can see the discussion going on. You will expand here, like maybe the resident knows already about this procedure, has tried it, maybe he hasn't. So the conversation continues. And after you have the discussion, we're going to ask again. So do you have any other questions about what we discussed? What was your main takeaway from this? So the resident answers, you're saying that a possible reason why I get a bloody tap is that I insert the needle too deep. However, I've never heard of this early stylet removal technique. So now you can make a plan together, right? So for our next shift, please review this paper on early stylet removal technique when performing lumbar puncture in children. And we can talk about it together after you read it. And also on the next time you perform an LP, I want you to practice using it and see how it goes. So again, you make the plan together and you make actionable recommendations. And the resident agrees for it. He says, thank you, I will work on these before our next shift. So again, this went through all this, the 5 steps of the prepare to adapt. Now contrast that to another scenario. This would be we give poor feedback at times, and we still have the best intentions, but you can actually see the difference in the content and how we deliver it. So in this case, same scenario in terms of we're going to observe a resident that has difficulty doing lumbar punctures. So the attending says, let's go perform this LP. I want to see you really see what you really know on how to do one correctly, and I will be watching you very carefully. So this creates a very different environment, a learning environment. Now you're possibly causing some stress on the resident. You haven't set any expectations on what you're going to be observing necessarily, or what's expected of him. And then after the encounter occurs, again, same observation. Let's say the learner struggles to get the space initially, and then it gets a bloody tap. The attending goes to the resident and says, you were very nervous during the procedure, and then you were struggling to the point that you had a bloody tap. Next time, try to relax, try a different technique, and you may have more success. So again, he's encouraging the resident, giving him kind of something positive, something to look forward to, but he's not being specific. And he actually focused on how the resident looked and what was he doing that may be perceived as wrong, like being nervous, and again, being more personal in his feedback. So the resident says, yes, I was very nervous since it's a child, and I always have a bloody tap. And so I was already nervous about that. And the attending agrees, yes, I agree, but hopefully you won't be as nervous the next time. There are things that you could have done differently as well. So you could read a little bit more about how to perform LPs, specifically in children. So again, he's also giving them like what he should do, but he's not being specific about it. And this will probably not have the effect that we would like. Now, this would be a scenario of poor feedback in terms of how the coach or us are going to be delivering it to the learner. But we're going to go now to another scenario where the one that is actually giving poor feedback is the learner.
Yep. And just so you know, this is an interactive portion. So scenario 3 is the underperformer. And we'll just give you the scenario, and then we can kind of talk through some models for maybe how you would approach it using this framework. So set up here, there was no preparation for an observed encounter, and you supervised a patient sign out from one resident to another. The resident was fumbling through notes and provided the following verbal report. This patient came with chest pain. They're waiting for a second troponin. I think the first one was high, maybe. I'll have to check. I think they had an AKI. I don't remember. I was going to ultrasound. It's just been too busy. I haven't done it. So just get the other trope and see what you think. So that's the scenario. And how would you apply the principles that we talked about today to this specific observation or encounter? I can't see who's on here with this.
I can chime in. Or are you looking for them to?
You can. Yeah, go for it.
Let's see. Let me come up with. So preparing. So I would, say, this is actually one of the most critical times of your shift. Not just from, like what happens locally, but nationally. This is recognized as, for every specialty, one of the most critical times where patient handover presents a lot of danger. So we take our time, and it's even to the point where we do it like in the OR, where there's actually a timeout, and there's opportunity to ask questions, to answer questions. And so we really need to, one, just kind of set the stage where we can sit down, we can look at the computer together, and then let's go through some of those things that you were unfamiliar with. I'm sure you had a busy day today, busy shift. So, let's just kind of start over and, make it a more accurate environment, adequate environment to be able to go through the sign out appropriately.
Yeah. Any other thoughts? I agree. So that's a lot in the preparatory, like setting them up and setting expectations and giving a supportive environment to practice those skills moving forward as well.
You can ask them if they have a certain way that they sign up patients, or some kind of format that they use, or, if they've ever been taught anything, if it's an intern. I know a lot of them do struggle with the sign up process and haven't really been taught anything formal.
Yeah. So asking them about their frameworks, so to speak, is another good way. And again, that gives us as faculty insight into really what their thought processes are more than the superficial layer. So you can see, do they even have a plan at all? Or maybe they have one and they're just not following it for whatever reason. They're too busy, and maybe there's something else that needs to be addressed.
Another way that is helpful in these situations is to ask them, have they ever received feedback on this before? Because maybe they were thought, or they were, maybe they never received the feedback, but maybe they did receive feedback and it was either they did not act on it, or maybe it was different feedback. And so it also gives you a starting point on where do they stand and where are going to be moving forward.
Yeah.
I think an opportunity here is there's one-on-one teaching for this individual, or we can think about how is this group sign out going overall, and is there an opportunity to do a full debrief with how everyone's sign out is, and not necessarily just targeting this individual interaction.
Yeah, I think that's great. That was going to be my next point, is especially in things as important as this, is when we start to work together to create this culture for our entire emergency department, then that expectation is always going to be in place. Like right now at the beginning, we might have to put in a little extra legwork to be like, hey, just so you know, I'm going to be observing you doing the sign out process. Here's some of the specific things I'm looking for. But once we do that over and over, and we all do it together, and we're all on the same page and have this same shared mental model, then we don't have to go through that step every time. The residents will just know and expect it and learn from it all together. Any other thoughts? I know we're running out of time here. We'll move along. So just a quick review here. These are the steps that we discussed to the prepare to adapt framework. And hopefully everybody is able to utilize this on your next clinical shift in some form or fashion. Play around with it, because it does take practice to make perfect.
Hey, excellent. This was a great review, and I always like listening to this. I think, I don't know if you all mentioned this, I logged in a little bit late. I was on another meeting, but should we consider like printing like a little summary of what I'm seeing right now, this current slide with what each one of them kind of covers, so that we usually do this sometimes at the desk or soon after we leave the desk. So like a little refresher every now and then would help.
Yeah, absolutely.
Discussing these things with the residents.
Great minds think alike. I actually already removed the Pendleton model that was there on my shift the other day, and I have almost finished one with this. So I will make sure it's printed out and on the desk by this weekend.
Awesome. Let me know if you need any help, or like once you have it, if you want me to take a look at it. That's great. Awesome.
Well, yeah, I'll appreciate any feedback on that. All right. Any final comments or questions from the group?
Is the Pendleton model like out of date? I thought it was like pretty specific. I like that.
Yeah. If you really look at the Pendleton model, or what do they call Pendleton Plus? There's a couple other ones. They really do all look at the same thing, because even the Pendleton is like, ask about what they think went well, and then what we tell them what they did well, and then ask what they didn't do well. The reason that we prefer the adapt one is because it doesn't make that distinguishment between like, hey, we're going to talk only about good and only about bad. Rather, you open it up to the beginning to whatever their perceptions were.
And another benefit is the fact that this one has the one version for the learner and one for the coach, right? So again, this is not just for us. The residents also have some expectations, and that if they get better at it, it just will make the whole feedback process improve.
So this has the prepare and then observe. What if we don't prepare and we observe something? Is there a way to kind of, they're not being prepared, they're being observed? How would you go about it?
Yeah, it's so obviously this is ideally in a situation where you can kind of set expectations from the start. I think that brings up a great point that you don't always get the time, like especially when you're coming on shift and they've already been working, or it's busy or chaotic and you miss something. It's absolutely fine to still go on with the adapt model without the preparation, but then let that plan together phase lead into the preparation for the next observation. Again, whatever, like the LP, last time this is what I observed. So my expectation, the preparation phase, is this time when you perform it, you're going to put those things that we talked about to action.
And like you mentioned, if the activity already happened and you didn't have time to prepare, then you don't necessarily prepare for the activity, but you prepare for the feedback process. So just still ask them, are you okay if I give you some feedback? Okay, if we give you the feedback here, do you prefer that we do it somewhere else? And then you kind of go from there. Okay.
I know we're 1 minute over, so we'll wrap it up here. Just a quick recap. Here were our objectives for today. And focusing specifically on number 3, we hope that everyone is able to apply this framework to your next educational encounter in the ED. And then we can all talk about how it works and what works for us specifically, and hopefully work together towards that common goal of a better educational culture and providing feedback for the residents. Here are our resources for this talk. And we'll end there. Thank you.
Thank you.